Good evening, everyone. Welcome to today's Zambia Ophthalmological Society webinar. I am Bunda Patel, and I'm going to be your moderator for this evening. Okay, so we'll begin with our introductions for this evening. So we're going to have three presenters, and we'll also have a short presentation from our sponsor for this webinar, which is BVJ. So we'll start with our first presentation, and then we'll proceed with the others. So our first presenter today is Dr. Felida Mwachalimba. She's a consultant ophthalmologist and head of the eye unit at Levi Mwanawasa Medical University Teaching Hospital in Lusaka, Zambia. She obtained her medical degree from the University of Zambia and specialist training in ophthalmology at Kilimanjaro Christian Medical Center in Tanzania. She has extensive experience in clinical ophthalmology teaching and eye health service delivery, having served at the University Teaching Hospital in Lusaka and Kabwe Central Hospital. She completed her fellowship training in oculoplasty surgery, orbital disease, and ocular oncology at the renowned Arvind Prasad Eye Hospital in India. Arvind Eye Hospital. She's also a fellow of the Zambia College of Medicine and Surgery, and she's particularly passionate about primary eye care and school eye health programs. She's been involved in school eye health programs since 2019, where she's been involved in training teachers in school eye screening in numerous training programs across Zambia, aimed at strengthening early detection and referral of children with visual impairment. Outside her professional commitment, she's a devoted wife and mother of 4 children, 2 daughters and 2 sons, aged between 8 and 18 years. In her free time, she enjoys running and regularly participates in road races and marathon events. So welcome, Dr. Mwachalimba. May you begin your presentation. Dr. Mwachalimba, are you able to share? Okay. We can't hear anything. Dr. Mwachalimba.
Trying to share my screens.
Okay.
A challenge. Yes.
All right, while Dr. Macharimba is going to set up the slides, if Mr. Jamin Shah, if you're ready to present your short presentation, you can go ahead with that.
Hi.
Hello.
Yeah. Hi. Yeah. I can. I can. Yeah. I can try and do that. Okay. Hi. Hi, everyone. My name is Jamin Shah. I'm from BVJ Limited. I. I just let me. I'm gonna. Um, share my screen. Hopefully it'll work. I don't know if that was a problem that Dr. Felicita was having. But let me just see once again. I think Dr. Brunda, I think the issue is that I can't share the screen. Just let me see. I think maybe I should be able to now. Yes. Can you see the screen now? Can you see the screen?
Yes, we can see your screen.
Yes,
Okay.
yes, we can see.
Okay. Yeah, thank you for that. So basically, I just wanted to, uh, you know, I think I know today's topic is talking about school screening. So the first thing I wanted to start out by saying is that we've put together a little bit of a document um, talking about fast screening and sort of high fast screening and effective sort of screening technologies. So this is basically the document. I've asked Dr. Vrunda to share this with everyone in the event today. And basically, the idea for us to talk about screening in general, and I think that's something that I think Dr. Felicita was going to be talking about, was, if we're doing school screening, we normally focus on the refractive error screening. But here I've basically got kind of quite a rich resource kind of document, which, you guys can kind of look at in your own time. But basically, the idea is that there are these small, very smart portable technologies which are fast and quite effective, which can cover a number of areas, like obviously refractive error, which is important for schools. We have another device called the smart eye camera, which can um, screen for things like cataract and dry eye, glaucoma, and then also conditions of the retina and so on. So um, that's the first thing I wanted to kind of highlight, that we've ourselves, we are a very comprehensive supplier of different kinds of eye health equipment. But the thing that we find really, really exciting is that these technologies are now around to help us be able to screen so quickly and so effectively. And one of the things that really is attractive about these kind of technologies is that um, they have the ability to strengthen the eye health system, because if you look at a typical eye health system, it's like a pyramid. You have the primary layer at the bottom, then you have secondary, tertiary, and quaternary. And the biggest weakness we find with the eye health systems, in sort of Africa and other low-income countries, is that we're not able to screen so well. And since that primary layer is the foundation of the eye health system, if that's weak, then this is where we see a lot of the problem in terms of, the weakness in the eye health system, the burden on the eye health professionals, and so on. So if there's a way we can strengthen the eye health system by making the foundation stronger, then it would be a win-win for everyone. And honestly, I think some of these technologies have the capability of making the eye health system stronger. So I think this was probably the first point that I wanted to kind of mention. The and And then the next point is, just wanted to share with you one particular technology I want to focus on for the rest of the presentation is the something called the Kaleidos. So this Kaleidos is a amazing device for doing refractive error screening. Let me quickly just show you a short presentation on it. Just 1 second. Hopefully I should be able to do it. 1 second. Here we go. Um, uh, can you hear the sound? Maybe there isn't much sound at the moment. Can you hear the sound, Dr. Vrunda?
No, we can't get a sound.
There's no sound.
Yeah, no sound.
But 1 second. Um, I've just stopped sharing. I'm gonna start sharing again. Let me see if it works. Mhm.
And then have him look a long way. All right. This is Bob Arnold. I'm from Alaska Blind Child Discovery, but also from Burma Vision.
You can hear.
Children go blind from amblyopia in America and in Europe, but they also go blind in remote parts of the world, like this part of Karen State, Burma. Adaptica is a company in Italy that makes a photo screener called a two-win. Looks like this. But now they have a device called Kaleidos. And Kaleidos allows the two-win to be used in places where the clinic may not have the ability to make things very dark. The way the Kaleidos works is a patient can look in the end of this and have photo screening in a dark environment, which is the right distance. This allows detection of amblyopia in children in time for the treatment of their amblyopia to result in good vision for the rest of their lives. Children in America, children in Europe, and children even in remote parts of the world can benefit from photo screening with a device like this. Thank you.
Janine, are we done? We can't hear you.
Anyone talking?
Can you hear me now? Hello?
Yes.
Can you hear me now?
Yes.
Oh,
Yes.
okay. So sorry. Can I'll, uh, is it okay if I go back to and just a little bit? Yeah. Okay. So basically, I think uh, uh, I think basically what I'll do is just show you this particular device. So it takes a refractive error in literally 3 to 5 seconds for both eyes. So it's incredibly fast. It's also height adjustable. So do you see here with this hinge, you're able to adjust for the height of the patient. So within, so from the age of 3 years upwards, you know, you're able to take you know, the exam for a refractive error exam for, you know, anyone you're screening. And then it also works on a battery. So you charge it overnight and then you can use it for the whole day without any power. And then basically it's got its own also built-in darkroom, which means that we can actually do screening in even a, you know, sort of bright sunlight on a field. And then we've also got the ability, it's portable, so it breaks into 4 parts. There's the that part here, that part, this one, and then the stand. They fit into a box, and you know it weighs about 4 or 5 kilos. You can take this equipment anyway that you'd like to do the screening. And I think you may have missed it, but the the what I was showing in this thing in Uzbekistan was basically they were able to screen about almost like you know 240 kids in 3 hours with one device. So I think that just one second.
Sorry, is this thing being shared? I'm not able to see anything.
Oh, okay, sorry, just one second. So can you see the screen now?
Yes. Thank you.
Oh, sorry about that. So I think this is now I'm going to sort of almost um, say this probably for the third time, but I think basically, you know, what I would suggest is, you know, maybe just, you know, look at the links on that first document I sent. Most of it is covered there. We've got a really fast, you know, screening device for refractive error, which is portable, can work without any power, and basically it's got its own built-in dark room, and it can you know be used in kind of even on a field in bright daylight. It's also height adjustable, so you can use it from the age of 3 years upwards. Yeah. So I think that's and then basically we've got sorry, yeah, 1 second. We've also got a screening mode in it, which I'll show you. Um, there's the ability to actually add, you know, a spreadsheet of people. If you already know who you're going to be screening and their kind of details, you can just, you know, set up a spreadsheet and import it into the system. And then once you've done all the screening, you can actually even export it. So this is how basically when you have done an exam, you get an initial snapshot of the examination. the main thing when you get the initial snapshot of every exam you need to look at is the reliability. The reliability, for some strange reason, is it's out of 9. So when you have a reliability of 9, that's 9 out of 9. That's really good, and that gives you, the reliability gives you the confidence that you've got a fairly accurate result. I mean, the device is quite accurate. It should be within half a diopter of your subjective refraction, and that's based on studies which have already been done. And there you go. You can see like the ability to kind of export refractive error exams. That's it. I'll stop sharing now. Yeah. So sorry about the technical problems.
It's fine. Thank you, Mr. Shah from BVJ. We'll be sharing the document in our groups.
Thank you so much.
So people can access the links to see how these different devices work. Thank you. Okay, so now we'll be proceeding with our presentations. We'll have Dr. Machalimba present our presentation. I'll just share the slides. Hope we can all see the slides. Dr. Machalimba, can you proceed?
Good evening. Sorry about the technical difficulties. I'm actually out of my outreach. I have some patients waiting for me. We're still operating. Thank you very much, Dr. Patel, for the introduction. Right from the beginning, I'd just like to say that my experience with school screening is entirely the teaching aspect of it. I'm not really involved in the outcomes of the screening, but mainly my expertise is, or rather my experience is with teaching the teachers how to screen children. So this is what my presentation will be about. Next slide, Dr. Patel. So eye diseases do affect children and obviously will affect their learning if they have diseases that affect their vision. And prevalence studies have highlighted the need for early detection of eye diseases in children. And school-based learning is essential and it's effective. And 2 studies were done in Zambia, in Kawe and in Kafue, which essentially highlighted the effectiveness of the school screening. Next slide. So why train the teachers? So teachers interact with children daily and they have the opportunity to detect early signs of eye problems in the children that they interact with every single day. They spend the larger part of the day in classroom with the children. So it's an opportunity for us to use them as a workforce to help in detecting eye problems early in children and also to bridge the gap with the eye health workforce. Next slide, Dr. Patel. So what is the rationale for using teachers as vision screeners? So in Zambia, there's a shortage of eye care professionals and specialists. So this makes universal clinical vision screening very impractical. We can't reach all the children or people that we would like to screen. So using teachers is an opportunity and a vehicle in which we can use to try and bridge this gap. And also teachers are in a unique position because, like I said earlier, they interact daily with the learners and can identify the early signs of visual impairment, which is affecting learning, if they are given the tools, that is, to be able to do that. Next slide. So also the impact on the learning outcomes. So if we train the teachers, then undetected visual problems which contribute to poor literacy in children and misclassification can be identified. For example, if a teacher is given the tools, a child who is misclassified, for example, as a slow learner, when in fact their problem is they can't see. And if the teachers are given the tools to be able to differentiate between the two, then we'll be able to assist the child and also prevent maybe early school dropouts, because if the teachers are given the knowledge and the skills to be able to identify and recognize certain eye conditions which can be treated, for example, then we don't end up with children dropping out early in school, because they would have been given the knowledge and the skills to be able to detect these visual problems in the children. And teachers with this added knowledge can be a very important resource in this regard. And also you can look at it in forms of task sharing, because it empowers the teachers with simple screening roles and supported by referral pathways for the children needing care. So once the teachers screen these children, then, because part of the training is not just empowering them with the knowledge and the skills of identifying different eye conditions that are common in children, but also give them the correct referral pathways so that children with eye problems are not delayed by going to for example, a referral center that doesn't have any eye health personnel. So the part of the training involves empowering them with the knowledge and giving them the knowledge of where to refer the children that have been found with these eye problems. Next slide. So what are the training objectives of this school screening? So it's to recognize common eye problems, is to teach them how to perform visual acuity testing. The training involves identifying learners that need referral and the correct referral pathway. The emphasis is not really on them knowing a diagnosis or knowing the condition, but being able to know that there is something wrong with this child and this child needs further evaluation or further examination by an eye health personnel, and they know exactly where to refer this child. And it also ensures that the correct referral process is followed to avoid delays. And what is the content of this training? So basic eye health knowledge, common symptoms and signs. So how to examine the eye with a torch, for example, how to check visual acuity. And it's a very interactive training process. So at the end of the program, and the teachers are evaluated and they learn how to check vision in the child, and also common signs and symptoms that the children will present with. For example, a child that is not able to see on the blackboard, what the teacher might notice is the child will be copying from the neighbor, not because they want to copy, but because they can't see from the blackboard. So those are some of the signs that we try to highlight during the training, or a child who has a terrible handwriting, or that could also be a sign that the child is actually not able to see, because the child can't see what they are writing and they can't see what is on the board. Or a child who sits in class and they tend to squint their eyes in order for them to see. So those are some of the part of the training involves for them to be able to recognize things that ordinarily wouldn't know that there actually would be a sign that the child has a problem with their eyes, or a child that is lagging behind in class, not because they are not intelligent, but because they can't see. And children in nature might not even realize that they have a problem in their vision, and actually their friends or their peers are actually seeing better than what they are seeing, because they'll probably think that is normal. So having emphasized those symptoms to look out for in the children that they teach. And obviously common eye conditions and how they present, for example, allergic conjunctivitis, leukocoria, whether it be cataract or retinoblastoma, or squint, for example, being able to pick up that this child has a squint and that there are options, because the myths that are surrounding squint, for example, are that just because maybe the grandmother had a squint or someone in the family had a squint, and they would sit with the child because they think it is normal. And being empowered with that knowledge, then the teacher will be able to realize, or rather know that, okay, the child can be helped once the cause has been found and can be treated. Next slide, Dr. Patel. So the skills that are gained at the end of training is that they're able to conduct visual assessment, they're able to observe external eye abnormalities. Like I said, we train them to examine eyes using the torch, and they're able to record and report their findings and refer to the appropriate health facility. So the teachers will screen the learners, like I said, and they identified suspected cases are referred for professional evaluation. So they are told where exactly they are supposed to go and refer the children. Next slide, Dr. Patel. So what is the benefit of training the teachers or using the teachers as a training tool? It improves coverage because we, as healthcare workers with a shortage, we're not going to be able to reach all these children that are in these schools. And there's also early detection of disease and supporting the prevention of visual loss because of the early detection. And the impact on public health reduces. There's a reduction in undetected eye diseases because of using this vast resource. And it also helps to improve academic outcomes because children that have got eye problems are detected early, and they are referred to the appropriate health facility where intervention can be put in place. And also it supports the national eye health goals of trying to reach as many children as possible, or rather as many people in the community as possible. Next slide. So the core knowledge and the boundaries for the teacher. So we try as much as possible with the training to emphasize that the skills that they learn are to recognize reduced vision and obvious, for example, eye misalignment, to ensure safety and effectiveness. And there are clear boundaries that are set out, defining what the teachers should do and not do, and not to overstep. So they are not trained to treat, they are not trained to give eye drops, they are not trained to intervene. The training is emphasizing on being able to recognize that a child has a problem and refer them appropriately, and there is no focus on them coming up with a diagnosis. So teachers during this process, like I've said several times, they learn the actual referral pathways, They learn how to document the referral, and there's also effective communication that is taught between the parents as well as the healthcare workers in terms of cases that need, for example, urgent referral. So the teachers are told to, during this training process, that they need to, once they find a problem in a child, that they need to communicate to the parents, inform the parents, and encourage the parents to refer, to take the child to a specific health facility where they can get the help that they need. And once they are given this knowledge, there's obviously improved teacher confidence in that they are able to be more confident about identifying conditions and be able to refer them accurately, and also in performing eye screening tasks as part of the training. Next slide. So some of the common errors that are observed during the training is, or during what they experience during the training, and when they have learned how to examine children, and they are now practicing, is maybe they'll realize maybe there will be poor lighting, so they won't get the correct VA, and they might not get the skill of getting the correct distance to do the visual acuity, and they might coach the children during the testing, or they might inconsistencies in occluding the child, and errors in recording and documentation. So since these errors are well known, during the training process, it is emphasized that when they are doing the actual screening of the children, they have to ensure that the lighting is adequate, that they have the correct distance, that they are not coaching the children, that they are occluding the eye correctly, and they have correct information on how to record and to document their findings. So there are two programs two
Dr. Hussein, but we can't hear you anymore.
Sorry about that. So there are two surveys that I just try to highlight to just look at how effective the teacher training force, teachers have been in identifying conditions and referring conditions appropriately. So there's one study that was done in Kafue district, which was vision screening in learners by teachers in Kafue district, and a prevalence study that was done in Kawe, where primary and secondary school learners were screened. Next slide. So in the Kafue district study, this was a teacher-led vision screening program where 18,700 children were screened by the teachers, and then the mobile eye health teams, so the ophthalmic personnel, then followed up and re-examined and gave treatment. And then in the Kawe study, this was a large cross-sectional study which examined 23,000 learners, and teachers did the screening and referred the children, and different eye conditions were obviously identified. So in the CAWES screening, the number of teachers trained, unfortunately, was not indicated in the study, but they referred from the 23,000 children that they screened, about over 2,700 of them were found to have eye conditions. So when they referred these children, of the 2,700 children, 81% of these children were actually found with eye conditions. And in the CAFUE study, with 158 teachers trained and over 18,000 children screened, and over 2,800 screened, referred for eye specialists to rescreen 100% of the children that were screened by the teachers were found to actually have eye problems. So this just, I put up this slide just to highlight that the teachers are actually a useful workforce in trying to identify children that have got eye conditions, because positive findings of 100% and over 80% are actually commendable, because these children probably would otherwise not have been able to reach the eye health personnel, where majority of them would not be able to reach the eye health personnel. Next slide. So I'll just talk a bit more about the CAFUE study. So the aim of this study was to evaluate the effectiveness of using teachers as first-level vision screeners, and the teachers were trained and educated on how to examine children and various childhood eye diseases. And some of the conditions that are part of the training, for example, allergic conjunctivitis, how would it present, vitamin A deficiency, bacterial conjunctivitis, white pupil, red eye, just to mention a few, squint, just to mention a few of conditions that are really emphasized in the training, and obviously refractive errors, because the majority of learners that are referred will either have refractive errors or allergic conjunctivitis. Next slide. So in the CAFUE studies, like I said earlier, they found 100% of true positive. So considering the high level of true positive, this just goes to show that teachers screening can actually be effective, and we're able to reach children that would otherwise not be able to reach if the children are, if the teachers, are given the knowledge, are given the skill, and they have the confidence of being able to examine the children and refer the children to the appropriate health facility where they can seek medical, further medical evaluation and medical support. And this strategy is valuable in reducing the workload also for the eye health care staff. Next slide. So what is the key takeaway for ophthalmologists? That task sharing is effective. So teacher-based vision screening is safe, and like the two studies have shown, is impactful when designed with clear roles and strong support systems. So having a support system, a strong referral system, having to know where exactly these children once identified will go and will definitely receive medical attention and further evaluation has been found to be effective. And the eye care personnel also have a critical role to play, the ophthalmologists as well as mid-level workers. And as we act as trainers and supervisors, rather than primary screeners, to ensure quality. So if we make use of this resource of using teachers to screen children, it will be able to somewhat reduce the load, in that by the time the children are coming to a health facility, you know for sure that you are dealing with a child that has an eye problem and has been screened and has been referred appropriately. Next slide. And finally, it is it's important that the teachers during the training and after the training are closely supervised, and regular practical training and supervision is essential in order for the screening to be effective and to maintain quality, as well as to address staff turnover. Because one of the problems that is there is that you go to a training facility and you train a number of teachers, and then they get referred to another facility where they might not know the correct referral process, but they will obviously have the knowledge, but might not know the correct referral process. So having targeting areas where you have teachers that are trained and retraining the new teachers that come on board in these schools where they have these established referral systems can help to ensure that we maintain screening quality and also to address the staff turnover. And also to encourage the teachers, even as they gain this knowledge, to transfer that knowledge to the teachers that are coming to join the school, so that we ensure that the staff turnover aspect is addressed. That is my last slide. Thank you very much.
Thank you, Dr. Machilinga, for sharing your insights from the Zambian schools that have the role of the teachers in identifying different conditions in children. I just want to ask the audience, we're going to change the program a bit. We're going to take a few questions if there are any for Dr. Machilinga at this point, because she has to continue with her outreach. So we'll just have 5 minutes of questions for her before we move on to our other presentations. So if there are any questions, please feel free to ask. Go ahead. Please go ahead, Stamoila. You can go ahead with the question. Luando. There's a raised hand. Is there a question? You can also type the questions in the chat. Okay, it seems like there's no question at this point. Dr. Matimba, thank you so much for your presentation.
Thank you, Dr. Patel, for giving me this opportunity. Going back, my patient is actually on the table. Thank you.
All right, thanks. Okay, so we'll proceed with our other presentations. Let me just check and confirm if our next presenters are online. Dr. Priya and Mr. Banerjee, you can confirm you're online.
Yes, yes, Doctor. I'm online. Saptak this side.
Okay, thank you. Dr. Priya? Okay, I think we can proceed with Mr. Banerjee's presentation. For now. I reconfirm the other presenters. Just share. Okay, so we'll just introduce our next presenter. So our next presenter is Mr. Saptak Banerjee. He's an optometrist and a public eye health professional and healthcare consultant from India with over 8 years of experience spanning clinical eye care, public health program management, health systems strengthening, implementation, research, and healthcare consulting. He currently serves as a consultant with Seva Foundation in the US and is also associated with Sight Savers India in their school eye health program in West Bengal. Alongside his professional commitments, he's pursuing an MBA in Hospital and Health Management in Jaipur with a focus on understanding and advancing the role of eye health within the broader public health and healthcare systems landscape. He holds a Bachelor of Optometry from West Bengal, followed by a postgraduate diploma in Public Eye Health and Community Optometry from LV Prasad Eye Institute in Hyderabad. He, as a public health program manager at LV Prasad, he led and implemented multi-state universal eye health projects, contributed to strengthening primary eye care systems, and supported a capacity building initiative involving 14 partner hospitals across India in collaboration with Seva Foundation. His work contributed to significant improvements in service utilization, referral uptake, program performance, and quality of care. In his current role with Seva Foundation, Mr. Banerjee coordinates, monitors, and evaluates nationwide vision center and primary eye care system assessments across partner hospitals in India. He focuses on monitoring and evaluation, mixed methods, health systems research, program quality improvement, and the development of sustainable models for primary eye care delivery. Collaborating with Sight Savers India on a research project in Bankura, West Bengal, where it was aimed at assessing the quality of service delivery within school eye health programs, evaluating spectacle compliance and its associated barriers, and exploring the challenges, solutions, and strategies for strengthening school eye health services through a qualitative research approach. The project also includes the assessment of visual impairment due to refractive error and the development of a monitoring and evaluation toolkit for eye health services. So his experience further includes participation in eye care service delivery for the Rohingya refugees in Cox's Bazar, Bangladesh, rapid visual impairment assessment studies, and contributions to peer-reviewed publications in ophthalmic epidemiology and clinical and experimental optometry. He has received scholarships and travel grants to present and participate in national and international eye health forums, including Vision 2020 India conferences, the IIPB regional meetings, and the ARVO India. His professional interests include school eye health, primary eye care, community ophthalmology, health system strengthening, program evaluation, implementation research, and healthcare management. Today, he will be sharing his perspective on the challenges and opportunities in school vision screening programs, drawing upon his experience in program implementation, research, and health systems assessment across diverse settings in India. Mr. Banerjee, welcome, and please go ahead with your presentation.
Yes, thank you very much, Dr. Brunda, for such a wonderful description of what I had done till date. I hope I'm audible and visible both.
Yes, you are.
Right. So I will not waste much time. I'll directly go to the presentation. I'm sharing my screen. Just let me know if you're able to see that properly. I hope it's visible.
Yes, it's visible.
Right. So thank you, Dr. Felida, for pointing out the very important factor of the school's training, that is the teacher's training, which can be very beneficial in today's world. Thank you for that. So I'll specifically focus on the challenges that we can face while running a school training program very successfully, and what can be the possible solutions to them. Because we are seeing that since last decade, uh, actually the number of school screening across the globe has increased significantly, which is a very good sign for the overall public health development. But the question remains the same, that is eye screening ensures the final outcome, is it sufficient, or do we need to focus on some other things as well? If so, what are those? So those challenges I'll try to focus in this presentation. But so basically challenges differ. If I'm talking about the challenges of the school screening in India, and in Bangladesh and in US, so this different challenges in different country can actually give you a different context, right? So these challenges don't resemble with each other, because that specifically depends on the socioeconomic aspect of that particular region, right? It differs from a developed country to a developing country. Specifically, I will try to focus on the lower and middle income countries, such as the South Asian countries like Nepal, Bangladesh, India, Pakistan, then the African countries like Ethiopia, South Africa, Zambia. So these countries are having kind of a similar context, which might not be similar to the context of US or the European countries. So the challenges of these particular countries are very different. So if you try to implement a successful school screening program, first you have to counter those challenges. And once you can address those challenges, then you can ensure that, okay, I can run a successful school screening program, right? So the challenges can uh, be originated from a lot of sides. It can be operational, it can be from the perspective of the population of that region. So those can also hold the success, right? And before directly jumping, is my presentation visible properly? Can anybody confirm?
Yes,
Yes,
yes.
it's
Right. Thank you so much. So before directly jumping to the challenges specifically that can arise in the school screening program, let's see what context is there in these particular countries. Particular countries means the low and middle income countries, the South Asian countries, African countries, right? So there, the main problem is a limited resource and investments, right? Some other organization will give us money so that we can implement a successful school screening program. That is the first and foremost challenge, right? Then the burden of other serious fatal diseases, which can eventually lead to mortality, right? Like malaria, dengue, other chronic diseases, other infectious diseases, nutritional disorders in children. So those are actually imposing much more threat than eye health disorders, right? So it's very difficult for us, like people like the eye health professionals, to showcase that the eye health is really important to the government, right? That is another big chapter of the challenge. Next comes the health system is very weakly integrated. The primary healthcare model, the secondary, the tertiary level of facilities are not rightly integrated. That is another kind of challenge. And the most important thing is, because of high poverty, it finally led to the low literacy rate, and which eventually resulted into the low awareness level of the people, so that it becomes very difficult to implement a successful school screening program, right? That is overall context of this kind of countries. Now let me jump directly to the challenges in the school screening program. And not surprisingly, that these problems are actually originated than the problems I told in the overall context. So the very first challenge we face while doing a school screening program is the quality of the program. It's very difficult to maintain the quality because we have lack of trained healthcare professionals, lack of infrastructure, right? Lack of resources. So what can be the solution? I'll come to the next slides as well. So the next challenge, I'll talk about the stakeholders awareness. And in school screening program, there are main two stakeholders. One is the teachers, right, with whom the kids usually spend most of the time of their days. And the second come the parents, right? So these two are the main stakeholders of the whole game. Then comes, once you are giving the spectacles or dispensing the spectacle, unless it changes its status towards the spectacle owned or spectacle used, that means the spectacle dispensed is changing its status to the spectacle worn, and the compliance is getting better, you are not able to make any point out of any school screening program. That's another big challenge. The fourth challenge, I'll talk about the high referral dropout. For the cases which are not manageable at the school eye clinics, you refer them to the higher facilities. But Are they going to those centers, or even if they're going, what kind of services they're getting? You don't have any particular documentation. So that can create another big challenge, right? And final and most important challenge is a financial constraints, as I told earlier also, that without money nothing is going to be possible at today's world. So that is a final challenge, as I subdivided, right? There actually are numerous challenges are there, but I tried to subdivide the whole umbrella of challenges into five. So now let's look at the quality of the program, which can put a big challenge if it is not done rightly. So simple mistakes, simple errors in the examination procedure, the equipment what they're using, right? The retinoscope or the simple the distance vision measurement tape that is not in the right track, that can also create a huge problem. So that 100 kids you missed detecting, so that can also create a problem, create a challenge. So this kind of minute challenges are there, and these challenges usually happen because we don't have a standard protocol, right? We don't have a standard supervision or a monitoring protocol, because only screening is not the solution. People are only going to the school screening, doing the refractive services and giving spectacles or other services is not the answer to a successful program. Whether those things are happening in the right way, are we able to detect as much as possible, uh, are we accurately rendering the services to the kids, that is important. And that's where we lack in the quality. So to understand more deeply this particular challenge, let's see the usual flow of the school screening program. What do you do? First, you identify schools, then you go there, you screen all the students, right? Then out of those screened people, you detect some of the kids who are having serious issues with eye, and after that you subdivide that what kind of issues are those, and as per that you try to give the intervention. So that is the usual flow. But the challenges of quality are actually hidden between these steps. So first challenge what we can see is the quality of detection after the screening. So how are you screening, what protocol you are following, what kind of chart you are following, who are screening, and how were they trained, and if they are following a particular protocol, who standardized it. All these things matter, right? So that you can detect the 100% of kids who really need the eye care intervention without compromising on the quality. The second kind of challenge in the quality can arise in the steps between 3 and the next: not having a right clinical protocol. Right, once you have identified the children with the eye problems, then as per the clinical protocol you decide that which is manageable at the eye clinics itself, I mean in the school, and which are not manageable. So in that case, if those are not manageable, you refer them to the further facilities for the further evaluation, right? So this is not possible once you have a certain particular clinical protocol, and that has to be standardized. It should not be like I am sitting at place X, right, and referring a particular child to the further center, and another person sitting at place Y managing it itself in the school because his skill set is better than mine. It should not be the case. This should be standardized and universal for all over the program implementation, right? So now the next challenge is raised after the refractive error is diagnosed at the clinics. I mean the school clinics, which are manageable at the school. So are the refraction done rightly? How do you ensure? You can't ensure because you don't have a monitoring protocol. You don't have a monitoring framework. So unless you can ensure those things, you are not sure that whether the refraction is happening rightly and the kids are getting the right spectacles, right? Same thing for the other section of people who got referred. So if you don't have a right referral protocol, as just I described that I can refer a particular patient, but somebody else in the same program sitting at another place might not refer the same condition because we don't have a particular referral protocol, and this can actually hamper the overall program performance, right? So then after you dispense a spectacle, whether those were dispensed rightly, were the frames tight fit or loose fit, so that after some time, after using 1 week or 2 weeks, I can guarantee the kid will discontinue using the glasses, right? And that will make the whole point of the program meaningless. So that's not going to make any change in that case, right? Same thing for the referral uptake. You refer some kids from one school to the other higher facility, but you don't have any right documentation whether they're going to those places or not, right? Unless you know that, unless you have documented that tracking, the whole program is not going to be successful. Finally, if the whole process is not integrated, so somebody sitting at the school level uh, does not know the status of a referred patients 1 month back. If that is not integrated, if that there is a knowledge gap in that level, the whole process will be just school screening and not ending the loop of service, right? So how to understand and how to resolve this particular issue? So there are a lot of school screening frameworks made by big organizations, big NGOs like Sightsavers, IAPB, WHO. But those frameworks are very long and very descriptive. So it's usually very difficult for the program coordinators to follow. But there is a lack of published monitoring and evaluation toolkit, which can rapid toolkit. You just go to the field, you try to implement it, just within 1 day you can understand what is the current quality of my screening services in the school, right? So that kind of monitoring and evaluation toolkit can be developed, and you can implement this in the field. So just for I made this toolkit a month or 2 months back for a particular school screening project with Sightsavers India. So you can just for a demo I have given it here. So it actually captures a whole description, starting from the status of the retinoscope, starting from the status of the vision drum, whether that's illuminated rightly or not, to whether the examination procedure is getting followed rightly, and whether the spectacle prescription is perfect. So everything is mentioned there. So you just go there with a pen and paper, you see as a project coordinator, you see the overall process, you just give a tick and score it, right? So finally, if you see that 80 to 90% score it's able to make after the monitoring, then you can understand, okay, my screening program is going perfect, but it needs certain polishing. But if you see that it's 50 or 60%, that means out of 20, if it's hardly making 10 or 12, that means you have to be very serious about it, that my screening is not happening as per the right quality. So this thing can generate an alarming situation that you have to be serious about your screening quality. So this can be one solution to that. So the next challenge is the stakeholders awareness and engagement. As I told earlier, the main stakeholders of the school screening is the teachers and the parents, right? The first is the teachers, because that's the most of the, they are the people with whom the kids spend most of the time of their day, right? And if they're having a lower awareness regarding eye care or eye health overall, it can be a huge challenge. As Dr. Felida pointed out in the previous presentation, that the teachers training, that's very important. And also I have seen personally that the teachers in specifically the rural areas of the South Asian countries like Bangladesh and India, specifically the deep rural areas, they are already equipped with a lot of other responsibilities, such as midday meal scheme, vaccination scheme of the children for other diseases like malaria or dengue, etc. So over that, if you try to teach them the eye care, eye screening basic protocol, it might be challenging for them, and most of the cases they might not be willing. So doesn't matter whether you train them, but it might not give you a fruitful result. So what I believe, what can be solution to this is, uh, first try to understand their awareness level regarding eye health. What is their reality, what do they think, right? What is their willingness level, right? So this is a picture of recent my visit in one of the rural places in India with site service. So I tried to organize a focus group discussion with the teachers to understand what is their point of understanding, and whether they're willing to contribute to this thing. So once you understand their reality as per their requirement, you can customize a particular teacher screening training module kind of a thing, so that they can do the basic screening. And even if basic screening is they're not doing that, still they at least would be aware. So if in their class one kid is sitting with a corneal ulcer, they will not avoid, they will understand that there is a white patch in front of the eye, and that layer is called cornea, because that public health professor professionals taught me that that's called cornea, and any white patch on that is a problematic thing. And the teacher will know that whom to report. That is your organization's team, right? Because you already have gone there and established a referral chain. So it will be direct and it will be beneficial. So by this way, we can actually uh, change a lot of things significantly. So that can be one solution to this particular thing. And for the second level of stakeholders, which are the parents, so their literacy rate in this particular countries, in the low and middle income countries, is very low, and they are dealing with lot other challenges of life like poverty, out of pocket expenditure, not stable economy, right? So those things are already in their head. So over that, how would you convert them from an unaware parent to an aware parent, right? So that is your duty, so that they can encourage their children to keep using the spectacles that you're giving in the schools, right? Why? Anyways, I'll show you later in the spectacle compliance slide why this is needed to make them aware. But how would you do that? Same, the qualitative understanding is very important. I'm not saying that it should be in a very rigid research protocol. Rather, your project coordinators just can go to the field with a pen and paper and just talk to them, that what do they think, and just record it. So once uh, record a huge number of understanding from the population or from the parents, you can club it down and you can understand, okay, fine, this is their reality, that's what they think about eye health, that's how they think that this much utility this particular eye screening is having in my kid's school. So once you understand that, then you can arrange behavior change communication campaigns in their community. So basically, if you want to do anything in any population in the globe, in the whole world, you first need to understand the nature and behavior of that community. Once you understand their knowledge level, then only you can go towards the attitude level, changing the attitude of those people, so that it can slowly turn into the practice, right? So that's what you need to do here. First, you understand in a qualitative approach that what do they think, then you try to plan strategies that how to make them willing towards this thing, how to make them encourage their kids in wearing spectacles. And why is that important? That answer is remaining in the next slide. Poor spectacle compliance, that is a third and very important challenge, right? Specifically, if we see that spectacle utilization rate, right? That means if you're giving spectacles to 100 kids, how many of them are using it after 6 months, right? So on an average, it actually varied very widely in the globe. It's starting from around 3% and going towards 93% in the US and other developed countries. But on an average, it's less than 40. It falls somewhere in between 35 to 40%. That means out of 100 kids, you're dispensing the spectacles, only 35 to 40 kids are using it for a very long time. That means other 60 to 65 kids are not using. So that makes your school screening program very pointless. And specifically, if we are looking at the African country statistics, specifically in country like South Africa, Nigeria, Ghana, the spectacle utilization rate is not even 5%. That means out of 100, not even 5 children are continuing using these spectacles. And what are the main reasons for that? The first and very important thing, which kind of acquired 30% of the whole non-compliance, is that parents don't encourage, rather they discourage their kids from using the spectacles, right? And I personally have seen that in the rural areas of India, Bangladesh, the once the parents get to know that my kid has to wear a spectacle, first they get very disappointed that why in this age they have to wear the spectacle. No, no, not needed. So that means they're not aware, and they basically discourage. So in that level, doesn't matter how much good refraction you do, how much good spectacle you dispense to the kids, after a certain time, 1 week, 2 week, or 1 month, ultimately those parents will discourage those kids that you don't need to wear this spectacle. So ultimately your whole planning will go in vain, right? So this spectacle compliance is a very important thing. We have to understand how can we resolve this issue. So very simple issue resolving strategy for this is, you go to those places. Suppose you have done this screening and given spectacles to in school X, right? The school called X. You go to the same school, you try to locate the same children that you have provided the spectacles, and then you get to know, definitely after 6 months or 1 year, and then you try to assess that what is the spectacle using pattern, how frequently they are wearing it, and if they are wearing it, in what time of the day they are using it the most, right? And do they like it, or what is their overall reaction to it? And if they're not using, what are the reasons behind not using it? Are their parents discouraging them? Are their friends in the schools taunting them or teasing them for their look, that the spectacle they're using? So I actually have seen a lot of cases like this. 2 weeks back, I went to Bankura district in West Bengal for this particular purpose, to assess the spectacle compliance in the students in the school. So the student, a lot of students are telling that I don't want to wear it because my friend, they taunt me, and or they teased me that you are looking very old, so they discontinued. Another barrier is they say that I don't like the spectacle frame because I don't look good in it. So that's where it remains, that when you are, that's where the part of quality or rule of quality of service remains. So when you're dispensing the spectacle, I understand you have done the right refraction. It's perfectly okay. But if the frame, spectacle frame itself, is not liked by the kid, he will not use it, or she will not use it. Specifically, in the around the age of adolescent period, the children very much they're very much conscious about how they look with the spectacles. So there you need to counsel them well, and you have to understand what kind of frames they're using. And a lot of cases we have seen that maybe 1 year, 2 years, 3 years back we have done the refraction. After that we did not do the follow up, so automatically the refractive error changed over time, and now they're not finding it useful to use it anymore, right? So that can also create a lot of uh, problems. So I use this simple questionnaire. You can see in the screen. It's just for the demo purpose. So that's how you can go to the same school and just assess what is their spectacle wearing pattern, frequency, what are the barriers that is preventing them from using the spectacle for a very long time. And once you understand those problems, you can plan as well to resolve those issues. Such as, if you understand the parents are not encouraging, so you can arrange the awareness generation program. Call them in the school, teach them why that is important, right? So in that case you can resolve those issues. The next challenge is a referral dropout. So other than the regular refractive error that you detect in the school, you give the glasses in the schools itself. Other than those cases, the cases which you find with the retinal issues, or glaucoma, or congenital cataract, or any complicated type of refractive error which is not manageable at the school clinics, what you do, you usually refer to the further centers for and further evaluation. But you don't know whether they're reaching there or not. So there is, if they don't reach finally, there is no point of making this whole referral, right? Even if you refer them, it's not going to make sense unless they reach there physically. So that is a huge problem. How to resolve that? This answers, two strategies can be followed. First one is a digitalization, because we all know that this is a era of digitalization. And once we can ensure that every step of a health pyramid is connected digitally. So suppose sitting at a school, I refer a student to the next primary health center. Sitting at the school itself, I will get to know that whether the student has reached there or not. If they have not reached, so I have to inquire why they have not reached there, right? What are the reasons behind? So only digitalization and integration can answer that question. Another thing to resolve this issue can be integrating the eye care services with the general healthcare services, because specifically in the lower middle income countries, in there's a huge lack itself in the general healthcare service, right? Eye health, there's a huge lack. The primary eye health center, the secondary eye health center, we don't have that much. There's a big gap. So whatever we have, let's utilize that. Whatever primary health centers or secondary general health centers we are having, we can incorporate eye health services in that itself. That can be done in two ways. One can be either you go there, you train their clinicians, you try to develop their infrastructure itself, and teach them how to do the eye screening, how to examine the eyes, and how to give the treatment. That can be one ways. But sometimes they're already overburdened with other serious diseases like malaria, dengue, vaccinations, and all those things. So they might not be that willing to do that. It can compromise your overall quality. So what you can do, you can put your teammates, your clinicians into their centers, right? So definitely after the right approvals and permissions from the authority, but you can make one of your teammates or clinicians sit there, one of your doctors sit there, so that directly the patients come to their primary general health center and get treated with the eye care service. That's how we can also ensure the referral uptake rightly, right? So these two ways you can approach that challenge. Now, coming to the final and most important challenge, which is a financial constraint, specifically for the South Asian countries, African countries, right? Because we vastly depend on the foreign investments for this kind of programs, right? So, what happens? Suppose you are running a good program, successful program, suddenly a war starts in between, a pandemic like COVID starts, and your budget or your whatever money you used to get from that country, that gets cut down. So you have to stop your program in between. So the only option is to be self-sufficient. And another problem is, in general, we have very high poverty in our countries, right? So that leads to limited capacity to afford the high out of pocket expenditure, because we don't have any insurance coverage for eye care services specifically. Although insurance industry has entered the overall healthcare sector, but they have not yet explored the eye care sector in that level. So that can be one answer. But how to resolve this financial issue, and how to make ourselves self-sufficient, so that we, uh, even if we depend on the foreign investments, we also should have our own resources, so that our programs doesn't stop in between. So that can answer that, policy advocacy and public private partnerships. So basically you collaborate with the government or public sector, and that can only happen when you can show an impact to them, that I am running this program, and the school children are your future citizens, which will make the country good, who will actually lead your country towards a better future. So once their vision is sorted out, once their vision is in the right track, we can ensure that our future is also in the safe hands. So in that, and for that you need to show them the impact. For that you need to run the program very rightly. You have to monitor and evaluate whatever I told till now. Those things have to be maintained. Only then you can advocate your generated impact to the government. And once you can do that, you can also push their budget separately kept for the eye care services in the national health policy. That can answer a lot of issues pertaining to self-sufficiency, right? And also encourage the insurance schemes, insurance coverage for the eye health, which can reduce the out-of-pocket expenditure for these people. And reducing out-of-pocket expenditure means directly increasing their willingness to access the eye care services. So this can be the solution to the problem of financial resources. So if I jot down all the things I have told till now, so because the very first thing is, screening alone does not guarantee your impact. Only you go to the school, you screen them, you give them a glass, that era is already gone. It's not going to work anymore, right? So you have to be very sure that your referral is getting completed. The people you are sending to the further centers, they are really reaching those places and they are getting their right treatment, right? The spectacle you're dispensing, the kids are really using those spectacles, and you're following them up after 1 year, after 2 years, whether to check whether the refractive error has changed or not. If they have changed, you have to go for another glass. Otherwise, finally it will result into a very poor spectacle compliance. So all those things have to be maintained properly. And the teachers and parents are very essential partners. Only screening and clinical services are not the answer. While those things are important, parallelly you also have to keep a very good relationship and awareness generation program in the community, among the teachers and among the parents, so that they, as the primary stakeholders, can directly help you in improving the overall program quality and making it successful. So that's all from my side. And any questions you are having regarding this, I'll be more than happy to answer.
Thank you so much for presentation and highlighting some of the challenges and how you've overcome them with the work that you've been doing in the school programs. I think we'll go into our next presentation and then have the question session because sorry, we're running over time with the little challenges we've been having this evening. We'll just have our next presentation quickly and then we'll have some questions at the end. I beg you to still stay with us, everyone. We have Dr. Priya with us now. Let me just introduce our Dr. Priya. Welcome, Dr. Priya. So Dr. Priya is the head of global program development at Big Vision, working across partnerships, programs, and product to apply her clinical and public health expertise. She has 18 years of experience as a public health optometrist with extensive experience designing and delivering eye health programs and research in over 25 countries. Priya holds a PhD focused on school eye health services and is an assistant professor at the London School of Hygiene and Tropical Medicine. She's a fellow of the College of Optometrists and the European Academy of Optometry and Optics. She previously served as the chair of the Public Health Committee at the World Council of Optometry for 3 terms. So welcome, Dr. Priya, and go ahead with the presentation.
Thank you so much. Sorry, it's probably late for a lot of you, but thank you for staying on. I will be quick as I can. So I've just asked to share screen. And you can see my screen and hear me?
Yes, to both.
Perfect. Okay, so I'll just make a quick start. So I've been given the last slot and the challenge to say, well, what does it mean to get it right? And my colleague Saptak before this went through a lot of detail about school eye health programs, so I won't go into that. But just want to share here sort of a couple of fundamentals of a school screening program. And so the first question I'm going to ask, and you can unmute or just raise your hand or show some sort of interaction to all of you, is how many of you go shopping? And this is not a silly question, it's a very serious question. How many of you go shopping? You go to the supermarket or the grocery store or, you know, to the local market to buy your groceries? I'm hoping you all say yes, but yeah, I've got 1 or 2 hands showing because I can't see. I'm hoping that, yeah, so there's a few of you that are going shopping. Okay, and before you go shopping, do you make a list? You make a list somewhere, I'm hoping. So I'll move on and I'll tell you why that's relevant. So my analogy of school eye health programs and how to implement them is always about going to go shopping and buying your groceries is always check what you've got in the fridge first, right? Or make a list. You know, too often I go to the supermarket without my list and I come back with snacks and a plant and batteries and not what I really left to get, which is usually at the moment nappies for my son. So my analogy is this: if you don't check what you have in place and you go and invest in something, then are you investing in the right thing? And it's the same with school eye health programs. So what I'm going to talk about today very quickly, within 20 minutes, I promise, is judge whether a school eye health program is actually indicated in a given setting, recognize the design decisions that you need to make, understand what a school eye health rapid assessment is, and then why monitoring and evaluation and effective coverage are not optional extras when it comes to school eye health programs. So why do we screen at school? And I think my colleagues have gone into this quite in detail. Well, because schools reach almost every child efficiently and equitably. But I'm still really aware that there are many children who are not at school in a lot of places, yet we still use schools and school health programs as a base to reach children. It's a practical route to reach children as well. We also know in child development, if the child cannot see, they're usually held back. And early detection would mean that they get treatment earlier and they benefit earlier as well. And having worked in so many programs in so many countries in the field, doing research, we know that many programs share the same flaws. They're either vertical, as Saptak was saying, you know, they're separate or one-off, or They sometimes bypass the health and education system. They're, if someone has some funding, they want to, screen children. A lot of the times they're refractive error only. And then they rarely outlive the funding cycle that created them. And also, we don't usually evaluate them or monitor them in a meaningful way. And what do I mean by that? So many times we see this, we screened 40,000 children. So the activity was completed, but did it make a difference? Those of you who've seen me present this before, I usually used to use a comic strip about this where, and I realize now that it's probably showing my age because not everyone was familiar with who Peanut and Snoopy were. And I used to show this cartoon where Stripe is saying, I taught Peanut to whistle. And then the question gets asked, well, you taught him, but does he know how to whistle now? And that's the difference. You can teach something, but has it made a difference? You've completed the activity, but has it had the impact it was meant to have? So the first thing I'm going to talk about is the fundamentals, things to think about before you screen even one child. So this is a question that most people actually skip. And it's, is this program even indicated? Screening is not automatically right everywhere, all right? It depends on what you're screening for. So what's the prevalence of uncorrected refractive error? What's the prevalence of other endemic conditions? Is trachoma, vitamin A deficiencies? And do you realistically have all the resources available for the problems that you'll pick up? And I tried to, just before this, get the exact data on Zambian context, but I'm sure one of you knows this a lot better than I do. But while there is a prevalence of refractive error, it's low. And it's low across sub-Saharan Africa. But it is creeping up. But it's not at the same pace or at the same levels that high myopia programs in, let's say, China, India, Taiwan, in those regions have. So importing a design that works in those regions isn't the answer. And sometimes the evidence-based answer is maybe not this, maybe not yet, maybe not here. And that's stewardship, that's not failure. So that's my first question that I always ask, like, what program, is there a program indicated? And then what type of program, design it so that it's relevant to the local context. Which age do you want to screen at? Who does the screening? Is it your teachers? But it has limitations. Do you have community health workers? Do they have other tasks? Are there other health teams going into schools? Can they do it? So, there's always relevant questions that you must get right at the beginning. What cutoff do you use? Yes, the WHO says 612. However, are you missing those children who would actually benefit? Because actually, in the environments that they're sitting in the classroom, the lighting is poor, the blackboard contrast isn't great. So can you screen at 6/9? However, if you screen at 6/9, are you increasing the burden for your next level of care? And is that facility equipped to deal with that burden? So it's things like that you want to think about. Where do you do it? In the classroom, in the hallway, use a chart, use an app? How often do you do it? And what about the ones that are not at school? How do you plan that within your program as well? So each of this is a very deliberate decision. It's a documented decision, which means that then every screening team that's going out is following the same protocol. And when you get inconsistency in this is when data isn't comparable anymore, and it starts to then become complex. So what happens after you've done the screening? The screening part is easy. That's what I say to everyone. The screening is really easy. But children start dropping out because there's a point in the whole pathway where they could leak out. So they get screened, they get referred, so they could leak out here. They get referred and they have a diagnosis of, let's say, an eye health condition or glasses, whichever ones they are. At each step, they could still drop out. And as my colleague said before, are they actually wearing? Is compliance happening? And then if there are other eye health conditions, is there any follow-up given? So, will your child actually wear your glasses? Or is there medication that's been put safely away and not being touched? And we would think this is obvious, but I have seen so many instances where a child has been given a pair of glasses and they think that they should only wear them at school. So what they're doing is they're putting them away safely and leaving them at school, and yet then they're going about the rest of their life outside without their glasses because they didn't know where to wear them and what to use them for. I also need to kind of bring this to attention because I'm so passionate about this that actually we shouldn't just be screening for refractive error. We need to think way beyond glasses because there is so much data out there now that says actually there is other pathologies, simple eye conditions that are non-vision impairing and affect how a children learns and participates in a class. So simple conditions, red eyes, allergies, dry eyes, itchy eyes, sensitive eyes, they all need to be dealt with because they all impact how a child learns and participates. So rather than vertical and one-off programs, it's really important that programs identify other pathology, treat other conditions. There's eye health education, the curriculum, teachers' needs are met, and that you work through the school health system rather than just going around the system. So this is the bit where I talk to you about STERA, which is a school eye health rapid assessment, which is a tool that is, for those who are familiar with RAB, STERA is a school version of RAB. And that's where I talk about, check your fridge before you actually go shopping. And your school eye health rapid assessment gives you that shopping list. It's the structured way of opening the fridge, writing your real shopping list before you actually invest in a program. So it's been co-developed with leading eye health organizations and experts. It uses the Peak Vision software, and it's rapid and comparable. So it's a baseline that you can repeat or benchmark or act upon. It consists of 2 modules, and I won't go into too much details, but the first module is basically where it assesses whether the environment is in place for a successful school eye health program. And then there's the magnitude module, which collects detailed specific data on eye health issues. And then they both work together then to ensure that a planned program is locally customized as well. Why implement one? Where there's no data, it gives you baseline data. Where there is existing school eye health programs, it allows for monitoring and evaluation. And where you want to advocate, it can be used as a tool for planning, funding, of inclusion of school eye health and national eye health strategies. Where have we used it to date? We've used it in 10 countries with 8 different partners. And there's 2 ongoing ones, one in Kenya and one in Mozambique and one in Laos at the moment. So it's a tool that's becoming more popular, more recognized in the sector, and is providing some level of comparability of eye health needs of school-going children in these different regions. So what we found, well, it's interesting. We've actually found, as we expected, that actually uncorrected refractive error prevalence was 4% in India in the schools, whereas it was less than 1% in Liberia. And then when we flipped it flipped for, let's say, conjunctivitis, where in India we saw less of it, but in Uganda we saw more of it. So it starts to make you understand that actually there's regional variation, and so programs should be planned based on that. These are just some examples of how it's been used. In Liberia, it's been used to provide data to their national committee, and it's now being used to plan and implement their school eye health program. In Uganda, we've just heard that the government is now considering a national school eye health program, and they've managed to secure funding from the Global Partnership for Education and World Bank based on the data that we provided from the SERA that was done in Uganda. And then in India, what we did was we compared the results from ASERA to what was being done in a program in the same region. And this was to validate the data and make sure that the tool was actually giving similar numbers. And actually, we found the similarities were so close. And so that was quite reassuring as well. So, and that I said, that was in India, where they compared the zero findings against actual program data, and they're remarkably close. So real world validation that the baseline reflects what programs go on. So you can trust it to plan. And then finally, the bit I want to talk about, which is quite fundamental, is monitoring and evaluation. And there's a difference. And I think it's sometimes monitoring and evaluation is stuck on a budget line as a last minute thought, or just as a last sentence in a funding proposal. And I think it's really important that you're doing both. Monitoring is when it's ongoing and recurring, and you're checking your progress against your objectives as you go, so that you can take any corrective action while the program is still running. So the question is this working right now? And if it's not, you take action. And then the evaluation bit is an objective judgment of whether the program actually achieved its goals and how it got there. So was this worth doing? And then the final thing I want to add is, you've all heard the term EREC, and it's becoming more and more important as we start talking about global indicators and the commitment that a lot of countries have now signed up to at the WHO based on Specs 2030, that there will be a 40-point increase in the effective refractive error coverage. Now, the problem is that we, in a lot of places, don't even have a baseline to say what it is. And so we're then asking, regions to say there's going to be a 40% increase. And unfortunately, that's really hard to measure. And so something that I've started saying for school eye health programs is, you need to know, at least at a school level, what is your EREC? And that can become a proxy to try to understand what's happening in other parts of the country or the population as well. And so EREC combines the access and quality part together and lets you benchmark your progress against regions and nationally. And then, I talk about this because it's really important, and this has been covered, but, what you need to make sure within school eye health programs is there's some quality assurance basics, like, are your screeners consistent with one another? How are you measuring that, monitoring that? Are you doing any refresher trainings? Are there any protocols? Are prescribing protocols followed and adhered to? Or is there overprescribing going? And then, is the worst eye genuinely being examined and not masked when it's being done binocularly? So again, questions you really need to think about in terms of quality assurance as well. So in summary, you need to get things right, and that's by having the right evidence. So I say open your fridge, look at it before you go shopping. And then comprehensive, see the whole child, not just the refractive error, really important. Work through school and health systems, and then measure quality and effective coverage, not just that the activity has been done. So check your fridge first, find out what eye health needs are, what services already exist, and then plan for what's genuinely missing instead of coming home with snacks, batteries, and no nappies, which happens to me often. So I'm going to leave you on that thought. So I realize that it's quite tight and time you've overrun already. But I've written a blog on this on the IAPB website. You can contact me for more information. But yeah, I'll stop sharing now.
Thank you so much for that presentation, Dr. Priya. I think it really highlighted some of the key points, especially whether the screening is necessary or not, rather than just wanting to start a program, right? Okay, so at this point, we invite questions for both the previous presenters. You can just mute yourself and ask the questions. If you're unable to speak, you can write in the chat.
Oh. Hello, good evening. My name is Vivek. I have two questions, one for Mr. Shaptak and other for Dr. Priya. So usually in our Zambian environment, what I have seen so far, I have done some school screening. Mr. Saptak mentioned that the importance of follow-up care at tertiary eye center. But for me, for many low-income families, the cost of transportation to this distance center is completely like prohibitive. So, what module have you seen that successfully address this? Let's say, for example, are there any mobile eye clinic that can bring tertiary care to the school, or a specific transport fund subsides that school can be assessed? This is the question for Mr. Shaptak. And then for Dr. Priya, in your Shara study, the one which you did for rapid assessment, did you find any challenges like here we generally find with our referral system, many parents end up avoiding the process of altogether, because teacher hand them lot of overwhelming amount of paperwork before you take out the children from the boarding school. So how can we simplify the administrative burden on the families? Are there any ways to streamline this process, perhaps through digital form or having a dedicated school help which can help the parent to find them out? Thank you.
Yeah, I can answer quickly what we've done in our experience. So, in a lot in most actually all the peak powered programs. So we work in all these different countries. We are using SMS or WhatsApp for communication with parents, where there's no actually paper or forms being sent. It's all done by SMSs or WhatsApp. We have also in some countries trialing voice messages to see what is increasing, referral adherence and what's getting the message across to the parents quickly, but also in a way that they are more receptive of it. Because you're right, even parents have so much paperwork and admin, and so sometimes it gets forgotten. But the one thing I'll say to you that I've learned in my experience, especially now as a parent, is that every parent wants the best for their child, right? And those of you who are parents on this call, like, you all want best for your children. So, but sometimes you may not have the means, or you may not have the correct information. And there's other challenges and barriers. But I think that what we have learned is that if the one that is in the control of eye care professionals and us is that we can learn to give the message correctly. Because if we can at least do that, then the parent knows what the problem is and what they need to do. And then, of course, there's all the other barriers, transport, affordability, everything else that we need to think about. But I think the one thing that is in our control is to get the information across correctly in the right way so that they understand it, because at least then we know that we've got that message across.
Uh, uh, Hello, am I audible?
Yes.
Yeah, Dr. Priya, I'd like to add one more point, specifically focused on the question that Mr. Vivek asked. It's a very intelligent question that I told that for the referral uptake, we have to track the patients that we are referring from the schools to the tertiary or secondary facilities. But if they don't have that affordability so that they can go to the centers, how will they, go there? Because they can't afford the transport cost. So what can be the possible solution to that? As I told that this era is of collaborations, right? So it can be the public-private model that you are approaching the local government or local authority or any local NGO that I am screening these students. I have detected that this many people really need further evaluation. All those costs is carried out by me only. I am taking that responsibility. If you can take the responsibility of the transport, maybe just by a simple minibus or a taxi or something like that from their school, it will just transport them to the treasury center. So that can answer a lot of questions. And if not, for the more complicated thing, in that case you can also approach a lot of companies. They are having their corporate social responsibility funds. So if you can convince them well, and if you can show them the right approach, that you are actually doing a philanthropic job for these kids, uh, to help them reach the tertiary center so that they can have the right eye treatment. So that can be one of the many ways. That's what I think. Yeah.
Okay, thank you for those responses. Any other questions? Okay, I can't get any questions, and there's nothing in the chat also. Okay, let's see. Before we just finish, if our president is there. Dr. Mumbi, do you have any final words before we close? Okay. I'm not sure if we're able to get him. Okay, well, it's been a very informative session, and I think there are a few school screening programs going on, but we have not on like lots of facilities that are doing. So it's we've learned a lot on how to things to think about before we actually start a program, and then the likely challenges we're going to face. So we have a hand raised here. Linda Mlea, okay, please go ahead before we just end.
Hello, everyone. Well, since no one is raising a hand, I decided to raise one.
Thank you.
Are you able to hear me? Yes. So I'm the coordinator. I'm not an eye specialist. I'm the one that usually plans activities, including school screenings at Lusaka Eye Hospital. So I just wanted to make a comment really on the use of spectacles, especially in children. That one is it's a really big challenge. I think more so in the rural areas, because the parents would always say that none of them used glasses as in their young age. So why should their child use glasses at this age? So there's a lot of education that needs to happen. And I feel that most of the time we've ignored this fact, and I'm happy to learn that we need to engage parents even before we start doing these school screenings. And I hope with that, I think we'll be able to see a lot of adherence to children using glasses. But otherwise, as it is, they would use the glasses one or two, not even a month, then they are packed, because the parents feel that the more the child wears glasses, the more damage their eyes get. So that is a belief which is out there. So I think it's very important that we educate them. Thank you.
Okay, thanks for sharing that. I think we'll have Dr. Mumbi just give us a few words before we finish. Our president, Dr. Mumbi, can go ahead.
Hello, thank you very much, and thank you for all the invited guests and the speakers, and for accepting our plea to come through and explain so that we can standardize and see how the rest of the world is doing the school screening. School screening, I think we're kind of each individual place is doing it, but I think we are doing it in isolation. Having seen how other areas in India doing it and what Dr. Priya also has presented, I think it, and also looking at what she has shown, what other countries are doing, it would be good to move towards that, so that eventually we can have a standardized way of doing it correctly. Yes, I think school screening is actually very important. Many of the conditions we see that many kids get saved and helped, like amblyopia and keratoconus, which is actually it is actually a lot in our environment. You notice the study that was done in Kenya, when Dr. Zara did a PhD from there. You notice that the numbers are quite very high. And what we see, because for us, every time we do a school screening, we'll see a huge rise in the number of patients that come to our service, because kids do not really come. The parents believe that kids do not get eye diseases, but they can get malaria and other things. So it's actually very important. So I'd like to thank the presenters who took time to prepare that, and everyone who has come along to come and participate. And I would also like to thank Mr. Shah for coming through. Mr. Shah has been a partner to us in Zambia in providing many different types of equipment. And I'm hoping that many people can start adopting such technologies that are there to make it easy. You remember, our bigger population in Zambia is composed of children, so it's very cardinal for us as a country to really focus on the children, and school screening is really where we are finding this population. Thank you very much, and hopefully we meet again next month at the same time, yet for another educational event. And have a restful night. Thank you.
Okay, thank you everyone for joining. And Dr. Priya, Mr. Saptak, and Dr. Machalimba for sharing your work with us. Good night, everybody, and see you at the next CME.
Thank you so much, and good night.
Good night. Thank you.
Good night. Thank you.